Here's a 55-year-old male. He's got hip pain from avascular necrosis, doesn't want surgery, says he's too young, he doesn't want to have it. He's taking extended release oxycodone, 80 milligrams 3 times a day. He's unemployed. And when I wanted to do a urine drug test on him, he said, no, I don't have to do it. It's within my rights to refuse. Nobody's going to know about me. I'm not doing it. What do you do with that?
Actually, we see those patients. I saw a similar patient who used exactly the same words. It's his right to refuse the urine drug screen. And as a primary care physician, it's my right to refuse to write the pain medications. It is part of the agreement and it's part of the mutual treatment plan. We all have to agree on the treatment plan. If one of the parties refuse part of the treatment plan, then it cannot be executed. When a patient like this comes, I believe that the best approach for a primary care physician to talk to the patient is, I will take care of your other needs. If you have other health issues, I will take care of it. When it comes to pain, I will not going to be able to do anything. This is essential part of the treatment plan. If you don't comply, it's your right, but also I won't be able.
What you don't understand in primary care, I've got the pain practice, and I confront people all the time in the pain practice, but in my primary care practice, where I've known these people for 30 years, confronting them is really hard. Mm-hmm. Challenging them is really hard to do. To say, you don't want to do a urine drug test? You can't do it. I'm not giving you the medicine. That is a very difficult statement to make.
Yeah, but Bill, it's your practice. It's your practice. You're taking responsibility. It's just like the surgeon has the responsibility with a scalpel, you have a responsibility with a pen and your prescription pad. You're the person who will suffer if there's something that adversely happens from you prescribing. Mm-hmm. What I hear when somebody refuses it or discussing a urine drug test, Doc, you think I'm an addict? Why are you doing it? And that's where I would say, no, it's part of my testing protocol. I test patients who are either 18 years old or 118 years old. It's part of my practice to do testing. And you have every right to refuse the test, but then I have every right to refuse prescribing you a particular molecule towards opioids and will limit what I could prescribe to you to treat your pain. So all I'm doing is firing the molecule. I'm not firing the patient or the treatment of pain.
Actually, I don't have any confrontation with the patient. I just say, that's fine. You know, it's hard for me to be able to continue with this type of treatment. We can move on to the other health issues that you have. When it comes to particular this one, unfortunately, is our policy. It's our care. And if you don't want it, that's fine. You know, we can move on. So it's not really in a confrontational mode. It's just in a more friendly mode that this is part of it. You don't want it. We're not going to do it.
Yeah, but I could see how that becomes confrontational because you say, well, I understand it's perfectly within your right not to do a urine drug test, and, you know, I'm just not going to be able to give you your extended release oxycodone. And the patient will say then, you don't trust me? What's wrong? You think I'm an addict, don't you, Doc? Don't you know me? I've been with you 30 years. Don't you know me? It feels really uncomfortable. So I understand that it's a friendly conversation, but it doesn't become friendly when you refuse a medicine.
But doesn't the patient know you for 30 years and that you're a caring physician, you're a knowledgeable physician, and you're trying to do the best to that patient for your practice, for your staff, for your community? So it's a bi-directional. It's not just one direction.
Michael.
Well, Bill, I think it is a relationship, and it is important to understand the patient's reason for refusal. And I think that you're right. They oftentimes do feel as if just the request for the test is an accusation of something bad, like being an addict. I think that you can normalize this, as Howard has described, by saying, this is part of my practice. This is how I manage these situations and these medications. But I can understand why you might be reluctant. I can understand that there might be some anxiety that this could go in a direction that you don't want it to. So explain to me what really is the hesitation or what is the anxiety here so that I can reassure you that I'm committed to taking care of you. I'm committed to making sure that your treatment is optimized in every conceivable way. But this is really an important aspect of making sure that the treatment is doing what it's supposed to do and that I can continue to help you in this particular way.
Let me just make sure I understand, because the audience may not understand. A person refusing, what does that actually mean? What are the potential issues related to refusing?
Well, they may have a toxic secret. They may have a secret that they don't want you to know, and you have to make it clear that whatever you find out or whatever you find on the urine drug test will not be used against them, but will be used for them to better their care.
So when you say toxic secret, Howard, you're saying cocaine may show up in the urine,
treatable problem,
marijuana may show up
problem
in the urine, the medicine that they're taking may not show up in the urine.
Opens a differential. Doesn't mean diversion is present.
The benzodiazepine that they borrowed from their friend may show up in the urine. So
treatable problem.
So one of the potentials is that something will show up in the urine that you don't anticipate, or what you want to show up in the urine doesn't. It may be just an issue about they think they're not trusted. So that's a possibility, right?
It is.
There's another possibility I can think of is I have this older patient that didn't want to be on opioids anyway, but clearly got better on the opioids. And her daughter comes in and says, I have to tell my mom to take her hydrocodone. She won't take it because she thinks she's going to get addicted. When I did the urine drug test, that was the final straw. She had never taken it. See, you think I'm an addict, and I thought so anyway, I'm stopping it. So there's the potential that that act actually pushes the patient towards not taking the medicine. And I think in our older population that happens sometimes.
I always bring them back to the same point that I have mentioned before. When the patient comes to your office, or the primary care physicians, our assistants, the first thing they do, they take the blood pressure and they bring it up to the physician attention that the blood pressure is high. The first thing the physician will ask the patient, are you taking your blood pressure medication appropriately? They said yes or no. I say, well, your blood pressure is high, which means we have to do something to adjust the medication. The same exact thing, when you bring it in the same regard, they may be similarity. They may understand why also you want to check. For the blood pressure, I can measure it. For the urine drug screen, this is how I can measure your opioid. So it's the same exact thing. It's just the stigma that came to it. We tried to take it off because this is now a medication that we try to monitor the medication. What comes to mind, though, when a primary care physician, and that's take it a step further, when they tell you, well, I checked the patient who refused to give the urine, and now they're in my office and they're taking 80 milligrams of Oxycodone. Should I give them prescription or not if they refuse the urine drug screen? And this is where I tell the primary care physician, I said, of course, you cannot give them the prescription. They say, well, they go through withdrawal. Said that's a choice that they made. It's not a choice that you made. So I don't want the primary care physicians to feel that they're obligated or they feel bad that the patient is doing this. This is the patient's choice. It's not our choice. We choose to help them. They chose not to get the help.
You want to make it clear to the patient that you're using the urine drug test to benefit the patient. It's not a punitive test. Urine drug testing is generally associated with the disease of addiction, performance-enhancing drugs that you see in the newspaper all the time. You want to use the urine drug test to increase communication and educate your patient, and you're not using it in a punitive way. That's what you have to get across to your patient.
So in this particular patient with the avascular necrosis, taking an 80 milligram extended release oxycodone, which has a really pretty high street value.
$1 a milligram.
$1 a milligram. And there is potential for that drug being diverted to the street. And I think the key point here is there's a lot of reasons people refuse to do urine drug testing, but we need to protect our practice so that if they're doing something wrong with it and we don't test, we're not protecting our practice. That would be one way. We need to protect the patient. If they have a addiction problem, misuse problem, we discover it, and now we can do something to help them with that.
And you want to protect the community that you live in.
Absolutely.
That the medication is not diverted and taken in the proper manner.
So it may be uncomfortable for that patient and you to confront the patient, but it's good medical practice to do that urine drug testing, especially when you have all these extenuating circumstances.
And you have 99% of your other practice depending upon you keeping your medical license.
Absolutely. I want to thank the panel for helping us with this discussion today, and thank you.